Hey, doctors, how many months between a Lupron suppression and the next stimulation?
Uh, I'm not sure I understand the question, but you would probably want to gap it at least 4 to 6 weeks before you tried another stimulation. Lupron suppression prior to stim has been proven to be detrimental. So that's not something we do.
Amazing audio now.
Oh, what'd you do? Button push?
No, in the settings in Windows, it says microphone or microphone, both the exact same descriptions.
So you
So I
chose
just chose the other microphone and magic Windows, baby. So yeah, I just chose the other microphone. That's
There
the
you go.
exact same description. Like not like microphone A or Asus or no. They're literally the exact same
Microphone or
thing.
microphone?
Microphone.
Wow. Sorry, dude.
Sorry, guys. You fixed it. Congrats. Well, guys, thank you so much. I couldn't have done it without you, to be quite honest.
Yeah.
What a stress. My God. I almost bought everything new again. I was also about to go on Amazon to start buying everything. Woo. All right. So, lesson learned.
There you go.
Pick the other microphone. Yeah.
Yeah.
Thank you, guys. You guys are the best. You have no idea the stress. Okay. Next question. Dr. V, what is your opinion on home IUI kits? Great question.
Um, they've been shown to have a lower success rate, but not unreasonable. Keep in mind, IUI in general is fairly low. I think people have kind of false expectations or inappropriate expectations of IUI, like this is going to work, but IUI is going to get you a 10 to 15% chance with pills if everything's really good, and maybe 20, 25% if you're doing shots. So, if you can get 5 to 10% at home, that's considered reasonable, but it's not great by any means.
I'm really relieved the audio's working. I was going to just throw my mind out the window. Mr.
Right.
T, could you please repeat a question about miscarriage? 2 parts. Could not hear the answer. I am so sorry. Completely my fault. But sure, let's go ahead.
The 11-week one with the fever.
The 2-part question, part 1 and part 2.
That was the fever one.
That was
right?
the fever one. Okay.
I don't know. You tell me.
Infection, endo, chromosome abnormality. That one. Yeah. So okay, I'll read it again, guys, because I don't know how bad the audio was, but if I got to read a question again, then let's get it right. Miscarriage happened on the 11th week. No tests were done on embryo. During this 11 weeks, 3 times I had a fever. Yeah, you're right. There's the fever. Twice low grade, and about 2 weeks before miscarriage, high fever. Have endo, and later part 2 diagnosed with ureaplasma,
Ureolyticum.
Ureolyticum.
Yeah.
I'm telling you guys, these medical words. That's what they do to get their, they use words that nobody would ever put together. 40 years old at the time. Would you say that most likely reason for infection, endo or chromosomal abnormality?
Yeah. So I was saying earlier that at the age of 40, you have a very high chance of having a chromosomally abnormal embryo, unfortunately. So that would be my number one guess, because in 60 to 80% of all miscarriages, the cause is a genetic abnormality. So automatically, that's going to be number one. Could it be a problem with ureaplasma? Yes, because ureaplasma in animal, but not human studies, has been associated with an increased risk of miscarriage. And I believe that it is in humans as well. From the standpoint of the fever, though, fever is a very substantial risk factor for miscarriage. So it is possible that you are struggling as a result of having had fevers, and that led to the miscarriage. Babies are not designed to withstand high body temperatures and all the inflammation effects that go on with a fever. So it's very possible that the fever has caused the miscarriage.
Is it possible to get pregnant naturally by having unprotected sex close to ovulation in a natural FET cycle, and also go ahead with the transfer? Will it affect implantation or transferred embryos?
That's what they were asking. Oh. Is it possible? Yes. Is it likely? No. I've never heard of that happening before, but it is possible. Yeah. Yeah. So it would be weird, but it's possible. The only thing is, you could, in theory, damage the natural embryo when you transfer in the IVF one. I can't eat chocolate in the middle of the show.
Just to, throw you off your game a little bit.
So
you pick me up.
Yeah, you can, in theory, damage the existing embryo if you put the catheter in and like the embryo sitting there and you're trying to go wherever, you don't know where that embryo is. So if you cross paths with it and knock it or damage it, you could kill the embryo.
Dr. V and Miss Dr. T, of course I'll answer this question.
Yeah.
Of course. Please help. You tell me what you need, guys. Would adding Omnitrope help with getting blasts? Dr. Victor, I'll leave that to you.
Yeah. So studies support that. There's a meta-analysis that suggests that using Omnitrope does increase the chances of developing a blast. So that's part of the reason we use it. And in fact, higher quality blasts as well. So that's why we use it. I originally was not a believer. Then we tried it because there were a bunch of studies. This is going back a long time. A bunch of studies that said it works. So we tried it again and then it didn't work. So then I said, okay, I'm not a believer. And then I saw the meta-analyses, which came out several years later. Like I probably gave it a 6 or 7 year gap. And then I was like, okay, this looks like it works. So then we went back to trying it and now we are seeing better results. Do I use it in everybody? No. Does it have side effects? Yes. A lot of our patients complain about joint pain that lasts way past the time that you use the HGH for, and swelling and joint soreness and stuff like that. But I do think it ends up working. It's just the side effects are brutal. And the financial side effects are brutal too. It's expensive.
Can you use Aestin? Aestin
Yeah.
For suppression versus Lupron letrozole?
Aestin is European, and I thought it was progesterone, but I'll look it up because I thought Aestin was a European progesterone. I could be wrong.
There is a lot of questions about Omnitrope today. Is there like a
like it's northestrone? No, you cannot use that instead of Lupron and letrozole. Sorry, it's not as strong, and there's no data supporting doing that.
Thoughts on Omnitrope?
Yeah, I was just saying I love Omnitrope. So for the right patient, it can be beneficial. More mature eggs, more eggs potentially, more fertilized eggs, more blastocysts, better quality blastocysts. However, no increase in live birth in the meta-analysis that's being published. So hard to know for sure.
Hi, Dr. T.
Oh, you just love that.
I even pause on it.
That stuff's going right to your head, man.
Going right there. Do you use Lovenox for patients who have endo or adeno, but is negative for coagulopathies? No. Of course I don't.
No, we don't use heparins for endo patients. I've never seen any data to support that that's beneficial, so we don't do that.
If there's no HLA mismatch or KIR typing issue, is lit optional or would you still recommend it? Thank you so much for sharing your expertise.
Well, we would only recommend lit in that circumstance if you had DQ alpha or low LADs. So if you don't have a HLA mismatch, no, we wouldn't do that. Only if you have the other ones.
Okay.
The search for questions has become quite the quest for you. It's not just like a next.
No, it's nothing like that.
I think you need a second screen.
You know what? The minute you click away, things move. So you have to like constantly move back and forth. And now for whatever reason, my screen resolution shrunk. And now I have to zoom in with my eyeballs to try and see what's going on here. That became new. So anyways, and then I'm sifting through audio sucks, audio's good. Now everything's perfect. Tarek, you're the best. Like can't read everything. Not everything needs to be read, So what we can read today is what is the optimal level of free T3s for fertility? Some doctors say 2.5 is good, but I read the optimal range is between 3.4 and 4.4.
Yeah, probably somewhere between 2.5 and 4.5. I would agree with that. We don't pay too much attention to the free T3. I don't try to micro titrate your thyroid. If your TSH is less than 2.5 and your T4 is okay, we don't focus too much on your T3 here. And I'm not aware of any evidence that says you should. So that's what we've been doing.
So this is a question for both of us.
Oh, there you go.
It doesn't say that, but I just felt like it should. How do you, which is us, choose the embryos to transfer? Is it blast day or is it grade first?
So we look for the highest graded blast on day 5, and then we'll compare it to the highest graded blast on day 6. And the lab will kind of decide which one they think is best, and that's what we use. So, for example, if you had a 3 BB on day 5, but you had a 4 AA or a 5 BA on day 6, we would take the 5 BA, not the 3 BB from day 5. So it depends, but we use a combination of the day, the expansion, and the morphological grading of the embryo. Your computer is working like serious overtime there, eh? The fan is just going.
It's going.
It's going.
There's a lot of things going on here. I'm telling you, there's real work being done.
I'm waiting
here.
to see steam or smoke.
I think it's going to fly. It's preparing for takeoff at this point. Hi, doctors. If the Fertility testing recommends an immune protocol with LIT and intralipids, if you are trying naturally, which one should be done first? LIT?
Well, you have to do the LIT first, because if you take the LIT with the intralipids, the LIT won't work. So you got to do the LIT first, get sensitized, and then start your intralipids protocol. So that one's easy.
My little sister did an egg retrieval for us last October, and so far the 2 best embryos have resulted in losses due to chromosomal abnormalities.
Oh.
She was breastfeeding right before her cycle. Could that have caused issues?
Not usually, no. I mean, I would need to know how young your little sister was, but no, typically that's not an issue. We would want to look at you, your microbiome, immunological problems, look at your sister's genetics, your partner's sperm quality. Like, there's a lot of stuff to look at, but we can definitely help you. Just reach out and we'll figure it out if you're not already our patient.
They're wondering, what clinic are you partnered with in the GTA?
Tripod.
Hi, Dr. V. Can I take melatonin during pregnancy to help with insomnia?
Yes, absolutely. You can. Melatonin is safe in pregnancy. In fact, it increases the chances of frozen embryo transfer success, and we use it in all our patients. So by all means, use melatonin.
How many rounds of letrozole normally till it works? 1 year TTC, never had a positive.
Well, it depends on your diagnosis. So, for example, if you have PCOS and you take letrozole over 6 months of use, it has a 27.5% chance of a live birth. That's from a study in 2000, I think, in the New England Journal of Medicine, where they compared head-to-head Clomid to letrozole. The author's name is LGRO, if you want to look it up, LEGRO. If you're looking at using it for unexplained infertility, so you went to the doctor, they checked everything out, they said you've got unexplained, here, take some letrozole. Total waste of time. It won't work. It has no increase in success rate. The success rate with letrozole is about 3.7% per month, and the success rate trying naturally is between 3.1 and 4.3% per month, so it doesn't help you at all. So it depends on what's wrong. You can't just say, what's my success rate on letrozole? It'll very much depend on what's wrong and what you're doing, sperm quality, body mass index, social habits, vitamins, lots of stuff, gut microbiome.
I broke my finger. Should I go to the doctor or should I just rough it out? Figure a little change of pace.
Change of pace? Yeah. Yeah. So I would go to the doctor, because if the fracture is unstable, it'll heal badly, and that would cause pain, arthritis, problems, deformations. Don't sit at home if you broke your finger. How do you know if you broke your finger if you didn't go to the doctor?
Because it looks like this. The claw.
Yeah, the claw. Yeah, I would go to the doctor and get checked out, or ER, or whatever you have to do.
Can flying affect implantation? Have to fly to and from my clinic?
No. We get people to fly in here all the time and they fly out the next day and they're all getting pregnant. So it's fine.
If I miss the trigger shot for IUI by 18 hours, is that detrimental on success rates?
Yeah, it can be. We had someone do that recently, so I wonder if that's that patient. But yeah, it can be. I mean, if you missed your trigger time, your egg could be post mature. You could spontaneously ovulate. There are factors that can occur that would make it less likely that you would succeed.
Why are some What are some reasons for not getting any blasts? Thoughts on freezing on day 3?
Sperm quality would be number one. Egg quality would be number two. Selection of sperm for the lab if they're doing ICSI. Problems in the lab itself, too hot, too cold, not enough gases, whatever, the pH is off, something like that, contamination, bacterial infections, that kind of thing. Genetics would be huge. DNA fragmentation is probably significant. So there's a variety of different things that could contribute. I think freezing on day 3 has been proven to not be as good as freezing on day 5 or 6. So we try to avoid that. But there are some patients where you just don't get success, so you don't have a choice.
Why is lit controversial, Dr. Victory?
I don't know, because there's a meta-analysis. So listen, I was not a believer in all the immune stuff until I met Dr. Zaneku at Tripod. And he kind of convinced me, and I started looking into it. Now, I don't believe anything until I see it myself. So I started doing the research. And that's not to say I don't trust Fred. I implicitly trust Fred. He's a great doctor. But I started doing the research to look at it. Like, LIT has a meta-analysis that shows a 45% increase in live birth. Like, that stuff is ironclad. I mean, no one can argue against that. So um, I don't know why it's controversial. If it is, people don't read. And a lot of stuff I find people don't read. I had a question from somebody that I work with who's running a new fertility company. And they asked me about another doctor's protocol, so to speak, where they had put a patient on meds. I won't get into the details in case I get in trouble, but they had put a patient on suppressive meds, and then they said, "Oh, you probably don't need it because things are going well." So they switched the meds, and the patient wanted to switch back, so they switched back, and then they switched again. Like, some of this stuff just doesn't make sense. Good example is Orilissa. So a lot of doctors are using Orilissa as a alternative to using Lupron in order to get suppression of endometriosis. Well, the problem with that is, number one, there's zero evidence that Orilissa is beneficial. There is one trial being run right now, and that's it. And it's being run. No one knows what the results are, to the best of my knowledge. Number two, Orilissa, if you look at the package insert, very clearly demonstrates that it keeps the estrogen levels in the mid follicular range, which is like a reasonable amount of estrogen. So that's not the same as taking Lupron and Letrozole. So you're still getting some estrogen, which is running that endo. So to me, I look at that and I'm like, there's no evidence. If physiologically doesn't make sense, if pharmacodynamically doesn't make sense, why would we be doing this? But loads of doctors are saying, no, that's what you should be on. Based on what? I literally have no idea. There's no evidence. They're just making it up on the go. So I don't believe in doing that. I want to study to support what I'm doing, or I don't do it. Now, there are some exceptions to that, but generally speaking, I want some kind of study to support what I'm offering people.
What are your thoughts on spindle view? I had a spindle score of 0.
I looked it up a long time ago. The data is not convincing. It's used by one of the clinics in Toronto. I don't know of anybody else that's doing it. It's like a big added cost. I don't know. I haven't bought into it yet.
Dr. V, if taking 2 to 3 days of Cetrotide before stims to suppress, what hormone levels are they looking for, and can I be cleared to start stims even before my period arrives? Thank you.
Why would you take Cetrotide before your stim? I don't know why you would do that. You don't need to suppress before stim. Stim can actually be started at any time. The cancer patients taught us that you can stimulate a woman at any point in time in the cycle, like your day 7, start. Your day 14, start. Your day 19, start, because there's going to be eggs that'll respond and you can go get them. That was the whole basis behind duostim. Duostim wasn't someone's genius brainiac idea. Duostim came because people figured we're doing it for the cancer patients. Why don't we just make this routine? So there's no reason why you can't just stim at any point. I don't suppress before the cycle. I vaguely recall reading something about that once, but honestly, I cannot remember the details of that one.
Laptop went quiet.
Your laptop went quiet, so it's probably going to die in the next minute.
Just one of those shows.
I'm kind of tempted to look up that Cetrotide one. Let's ask our friend.
All right. While you're looking that up, let me pull this up for you.
Yeah.
If there's a HLA mismatch, we did that one, right? With the KAR?
Yeah.
Okay.
Yeah.
Dr. V, I'm taking Cetrotide. We did that. Spindle score. When is the best time to do an ovarian probe before an egg retrieval? Is it safe to do during menstruation?
Ovarian PRP?
Must be PRP. They wrote on PRO, but
we usually do it around day 7 or 8, where you can start seeing an egg develop, so it's easier to poke into the ovary. You could do it during menstruation. I wouldn't. There's probably a higher infectious risk, and it is a not exactly 100% sterile procedure, so I'd be cautious with that one. Yeah.
Hello, doctors. I feel that fertility journey. Hold on. Something just popped up on my screen. I feel that the fertility journey is the end for me.
Is at the end? Okay.
Is the end.
Oh.
Is the end for me.
Okay.
That's it. I think this is
I'm really sorry. I mean, the hardest part of infertility for me is helping patients safely navigate that journey to a conclusion. Whether it's successful or not, it's not always successful. I mean, I would love to tell everybody that we are, 100% successful, but we're not. Nobody is. That's just a lie if anybody tells you that. So there are going to be times where we fail. There are going to be times where we fail with donor, with surrogate. That whole genome sequencing thing we did last week was because there are people that fail even when they take their embryos and put them into surrogates. Even when they're using donor egg, donor sperm, you can fail because there are genes that are essential that are mutated. So not everybody succeeds, and getting them to that understanding of this isn't going to happen. I mean, that's devastating for anybody. It's brutal. And I hate breaking hearts. I spoke to a couple today who had a very complicated case, and they had not had a chance yet to speak to the fertility specialist at the other clinic they were checking out, because I guess I was like another opinion. I guess I was the first opinion, but they had already pre-planned the other one. I don't know what that makes me. Anyway, so I was kind of explaining everything to them, and no one had kind of gone through that, and they were very complicated. And there are some very tough decisions that they're going to need to make, because it wasn't just one thing. There were multiple different factors on multiple different aspects. Structural, genetic, hormonal, inflammatory, all sorts of stuff. And so, that's hard. Like, it's tough to tell people bad news, especially on freaking Zoom. Like, it's one thing to sit face to face someone and be able to hold their hand and say, I'm really sorry, and you have my condolences, and here's a box of Kleenex, or my sincere sympathies, or whatever. But it's another thing entirely when you're delivering bad news to people on Zoom. And I do really hate that. But I also don't want to be dishonest. So it's like this super delicate balance of how do you deliver this terrible information in a humane way while maintaining your integrity and honesty and trying to help people so they don't waste a ton of time, they don't waste a ton of money. Here's the pretreatment with GnRH antagonists. These studies suggest that pretreatment with a GnRH antagonist before IVF stimulation may increase the number of eggs retrieved, but does not significantly improve pregnancy or live birth rates. There you go. Randomized controlled trial. Oh, let's just go over this one. Randomized controlled trial, reproductive biology and endocrinology. Damn, that's a bad one. This large RCT analyzed GnRH antagonist pretreatment with the GnRH antagonist protocol applied to normal ovulatory women undergoing IVF ICSI. The number of retrieved eggs and pregnancy outcomes did not significantly vary. There you go. I guess that's why I don't do it, because it doesn't work. And they looked at 136 women split into two groups. Yeah, I don't think that makes any sense to me anyway. So that's not something on my radar. But if someone's doing it, I would love to know. Definitely not beneficial according to this. Yeah.
Can breastfeeding before a stim cycle cause egg quality issues?
Well, they asked us that before, probably the sister one. Not that I'm aware of, although it'll cause fewer eggs, but I don't think it'll cause egg quality issues per se, or at least it shouldn't.
Is a fresh transfer or a frozen embryo transfer better for someone who is 43?
Oh, that's a good question. It's a balancing act. On the one hand, you're probably not making a lot of embryos, and getting them in without freezing them is one less intervention and manipulation, which physiologically makes a lot of sense. No proof for that, but it does make sense. But from the standpoint of your age, you also probably have an 85 to 90% chance that embryo is genetically abnormal. And so we would strongly advocate for you doing PGT so that you're not wasting your time putting the embryo in if it's not normal. So I don't know that there's a right answer there. You've got to weigh the I'd rather just wing it and see if it works approach to the I want to know if my embryo is normal or not approach. I don't know that there's a right answer. Let's throw back to the audience. Why don't you give us your opinions and tell us fresh transfer or frozen for the lady that's over 43? So it'd be fresh transfer untested or frozen transfer with PGT. Tell us what you think.
Let's see. The
we can't do like a poll, can we?
We can.
Oh yeah, you got to put up a poll.
Okay. While I'm putting up the poll, frozen PGT due to age is what one person said.
Yeah.
Frozen PGT due to age. Anybody else wants to go on and make an educated guess here? After unsuccessful IUIs, 6 of 6, and IVFs 2, is there anything you would suggest we are experiencing unexplained infertility? Found I have endo after the 5th IUI.
Oh my gosh.
But they were able to remove.
I would need to talk to you. I need to know everything about the sperm quality, your health habits, your body mass index, your nutrition, your microbiome. I would need to know about your immune system. How bad was the endo? What kind of protocol did they use for your frozen embryo transfers or your IUIs? We have a dedicated endo protocol. So, I mean, I would need to see if that's what they did for you or not.
Somebody said FET. They would go with the FET.
Yeah, frozen.
Yeah. Frozen with PGT. Another person.
I think that's what I would do.
That's what you would do.
I don't think there's a right answer, but I mean, why would you transfer an abnormal embryo? Having said that, there's a very significant difference in cost.
So between the fresh and the frozen?
Not the fresh and the frozen, because we don't care. It's the same price either way, but at least at our clinic. But the PGT adds a lot.
Is the optimal level of a free T3 between 3? We did that one. Yeah. Mm-hmm. How about Lovenox for endo and RPL?
We did that one too.
I'm just going to pass fault a couple of them. TMan. That's what it says. TMan. Ask Dr. V what he recommends for a 42-year-old that had egg retrieval with no eggs retrieved but 1 GV, more than 36-hour trigger, 20K HCG, and 40 IU of Lupron. I asked it.
Did they flush? And how many follicles did you have? So I would want to know, did they flush? Was it a cyst? What were your hormones like? That would be my question there. I mean, we never come out of the follicle until we get the egg, or I've flushed 12 times. If I flush 12 times and I can't get an egg, then I'm going to abandon it. But I won't give up until I try and get that egg. And sometimes it's like on the last one where we get the egg out. Frustrating as hell, but sometimes that's what you have to do.
My sister was 34 at the time of her cycle, has a healthy 2-year-old, and
That's
is
the
already
breastfeeding one.
pregnant. Is it?
That must be the one that gave the one that was.
No, I think it's a different one. I think it's a different
okay.
one, but it sounds
All
just
right.
like it.
Okay.
It sounds like it's the same thing, but
Okay.
it seems like it's different. Has a healthy 2-year-old and is already pregnant again after trying one time.
Yeah.
We tested the POC and it showed chromosomal abnormalities on the maternal side. What are the chances my remaining 2 are abnormal too?
No, that's the same one.
That is the same one.
Yeah. I don't know. I mean, at 34, there's a 50-50 chance that the embryos are genetically abnormal. So it's very possible that, unfortunately, if you didn't do PGT, those were the ones that were abnormal, and you have 2 more that are the normal ones. So I would check. Yeah.
They add that the sperm is healthy as can be, and uterine environment is optimal.
Yeah, I mean, it could just be genetics. Not that there's anything wrong with her eggs. She's 34. Half her embryos are going to be abnormal. You may have just gotten really bad luck, unfortunately. So I would just, I would want to talk to you and learn everything about you. So I don't kind of give you an off the cuff response, but certainly just trying again would not be unreasonable in that circumstance.
How do you know if flushing was done?
You got to ask.
Gotta ask.
Yeah.
Well,
we bill extra for it now because it's really expensive to do. So with us, you'd know because we were billing you for it. And we send you home on antibiotics after. So you'll know with us. If it was with somebody else, then, that's a different story.
Where are you located and how do we book with you?
Windsor, Sarnia, St. Catharines, Woodstock. Contact info@drvictory.com or go on the wonderful website Tarek made and contact him from there, or us from there, I should say. At the bottom, there's always a pop-up that says, do you want to book a consult? So yeah, there's lots of different ways to get through to us, or just call one of the offices. It's all on our website.
What is your best explanation for high prolactin results?
There's a gland in your brain, right, like kind of behind there, called your pituitary gland. And in the front part of it, you have the gland that produces prolactin. And sometimes it gets swollen and no one knows why. And when it gets swollen, it starts producing too much prolactin. So that's a pituitary microadenoma. Other reasons: chest trauma, breast implants, chronic nipple or breast stimulation, antipsychotic medications, some antidepressants, drugs that enhance bowel motility, domperidone, stuff like that. All of those can impact your prolactin levels.
If I'm located in Alberta,
yeah,
can I still book just a consult for information?
We have so many patients from Alberta. We're actually looking at moving to Alberta. So yes, for sure.
Hi, doctors. Do you recommend taking endoprotocol supplements? Which ones, AM and PM?
So the basics: prenatal vitamin, coenzyme Q10, vitamin D, iron, your fish oils. And then we do NAC, curcumin, resveratrol, and ALA. That's what we use. You should definitely take the advice of a qualified physician. You should make sure everything applies to you. Do not take anything we are saying as advice. It's just what we do.
I am ovulating straight after my period. Is that bad? And how do I ovulate later?
Yeah, that doesn't make any sense, number one. And how do you ovulate later? We've often used letrozole or Clomid to control that, or take the birth control pill for a month or two first to just shut everything down and it might reset itself. That's worth a try as well.
Do you normally continue immune meds and or fragment past the first trimester?
Most of the immune meds, no. Intralipids, our patients are terrified to stop. So some of them continue, and that's fine. None of the other stuff, the steroids, the tacros, the stuff like that, we stop. Aspirin, we continue. Heparin, we continue. Yeah, the rest of the stuff we stop, unless there's a reason you need to be on it. But if you've got a immune condition that necessitates you're chronically on steroids, we're not going to stop your steroids. But if you're taking it for fertility, we'll stop you usually after the first trimester.
Can you take metformin during pregnancy?
Yes, absolutely you can. We never did it very much in Canada, but in the US, it's like very commonplace. So absolutely you can. Yeah. I think we're done.
Well,
one more minute.
Yeah, okay. We'll give it a little bit.
Yeah.
Have you checked for a C-section? Oh, no, that's a comment to a comment here. My neighbor is 43 years old and had a fresh transfer. Beautiful baby girl. Fresh and untested since PGT is fall. Dr. V, do we have an update on the in-house PGT testing?
Yeah. Probably end of June, it should be ready to go. That's what we're hoping for.
I am ovulating straight after my period. Is that bad? And that's a repeat. What vitamins do you recommend for testing and optimized fertility? I've done vitamin D, B12, and folate. Anything else?
Fish oils, iron, melatonin, coenzyme Q10. Those are the big ones.
Would love to hear Dr. V's thoughts on AMH impacted by being a fragile X permutation carrier.
Yeah, that's a problem. So if you're a permutation carrier, you're at risk for expansions or something called frataxia if you have a boy. So your AMH can decline more rapidly. You should seek a long consult with a fertility specialist who knows a lot about Fragile X. So that's really important.
I'm 48 years old and have 3 frozen 3-day embryos with good grading. How many more egg retrievals do you suggest I do before transfer?
She's how old?
48.
At 48, probably 95% of your embryos on day 5 or 6 are genetically not normal. So in theory, you need somewhere on the order of 40 day 3 embryos to just get one normal day 5 or day 6 blastocyst. You would need a lot. So, I mean, in fairness to you, I would probably want at least somewhere between 6 to 10 day 3 embryos to say you gave it a reasonable shot, but we would never advocate for you doing day 3 embryos at 48. That doesn't make any sense. You need those PGT tested because you already know most of them will be abnormal. So I would suggest you grow out your other ones and get them tested. Okay.
Good?
Yeah.
Okay.
You guys all have a wonderful evening, and thank you for all your questions. Sorry for the sound problems at the start. We will make sure we select the right microphone next time. And you all have a wonderful time this evening. We will talk to you all again next week on Fertility Fact or Fiction. And now I'm going to have the chocolate.